Or I am recording during the quiz time. So Kaylee and Courtney, cameras on, please. Hey, Kelly. Kimberly. Jasmine's here.
Silence my phone.
You can do either way.
Are we allowed to have a blank piece of paper for the math?
Yes, yeah, piece of scrap paper would be fine.
Okay.
Just make sure it's blank, without any notes on it.
Did you say that we're taking this on Canvas or on example?
Yes,
file?
No, on Canvas.
Okay, because this says that it's locked until now, but it's not unlocked.
That's right. That's right. You have to have an access code. I'll give it to you.
No, I mean, like it won't even, it doesn't have anywhere to put an access code or anything.
Let me see here. When you click on the quiz link, it should show up at 3 o'clock. At 3 o'clock.
Oh, okay.
So we got another minute. Okay. Okay, Rebecca, you need to turn your camera on, please.
So I'm on this camera. This one's my computer.
Oh, I see you. All right. Well, then you can shut off the other one. I don't need you on both. But I don't want to complicate things either. So if you're fine the way you are, I'm fine. Okay. Everybody do a little bit of preparation, I hope. Looking through the PowerPoints and no, Fritz? Well, no, that's not a way to get started. Unless you watched a recording from last week. And because even if you didn't prepare for this week, you still should, if you got all the other questions right and the math right, you still should get an 8 out of 10. Okay, Sam, can you tell me what campus you're from? You don't have it. Sam?
Fortis, sorry.
Which Fortis? What?
Fortis, Cincinnati.
Cincinnati. Okay, thank you. And then Rachel, where's Rachel? Anybody know Rachel Prague?
She has to repeat maternity because she missed the Sims lab, so she's not in it.
So she's not in what?
In the class because she has to take it now next semester since she missed the Sims lab.
Oh, okay. Thank you for telling me. Yeah, those attending simulations and clinicals when you're scheduled is a good idea because sometimes it's really hard to make them up. You know, we might not have enough instructors or the facility might not be available to you. Okay.
Is it okay if I use this calculator?
Yes, you may use your personal calculator or hold it up so I can see them. I saw yours, Zaina.
Oh.
Okay, Sam, thank you. That looks fine. And then you can use the one on your computer. Is everybody ready? You have to be on camera, Cole. You step away and I hunt you down.
Let's grab my calculator.
Okay. All right. Everybody ready? Got a piece of scrap paper and a calculator. You have one simple math to do. Very simple. Okay, so a minute and a half. Okay, so you can get started. Click on that quiz, and the access code is uppercases. O-N-U-R. O-N-U-R. Uppercase. And then remain quiet. So mute yourself. And when you're finished, just turn your camera off. That way I know you're finished.
Can you repeat the code, please?
O-N-U-R.
O-N-U-R. O-N-U-R. Upper letters.
Yep, all uppercase. Mhm.
Do we start now, Miss? Hello?
Yes, start.
Okay, thank you.
Yeah, quiz 1, week 2, Leslie. In your Canvas module, week 2. Okay, I think everybody is finished, correct? All right, turn your cameras back on, please. All right, Haley, are you there? Or did you step to the bathroom? And that's fine. So during class, when we're talking, if you have to go to the bathroom, you don't need permission. Just come right back, okay? Just come right back. Don't sign off. Don't turn your camera off. Just come right back. Just go and come right back, okay? Okay, I'm going to go over, since all the classes, I've taken the quiz now. In all of my classes, I do want to kind of go over some of the concepts that were commonly missed. When we talk about clients that have, and we're going to review it again today, but clients that have a medical history, chronic illness, clients that don't have the resources they need, and other things, they're automatically at high risk, even day one of their conception. So obesity is a risk, okay? A client might be healthy in every other way, but if she has a BMI of 30 and greater, she's obese, so she's at risk, okay? 30 and greater, okay? A diabetic, a client with high blood pressure, a client with kidney disease, heart disease, a client that doesn't come to prenatal visits is high risk, because it's important that they come to visits to follow with the pregnancy, make sure everything is going well, okay? Neural tube defects. During the first 8 weeks of pregnancy, the embryonic development, it's a zygote, it's a blastocyst, then it's an embryo. So it implants not usually before 7 days, okay? But usually by 10, 12 days, it's nicely seated in the nice cushiony vascular bed of the uterus provided by the progesterone, okay? So during those first 8 weeks, all the organs are developing, right? And at the end of the 8th week, all the organs are in place. And specifically, if we look at the neurological development, the brain and the spinal cord, that spinal cord has to be covered up completely, okay? And sometimes if a client doesn't have adequate folic acid, which is B9, vitamin B9, it's a growth hormone. And it's required to have adequate levels of folic acid during those first 8 weeks. And if not, then there might be a neural tube, which is the brain and the spinal cord, a defect, okay? Some of the brain might not be completely developed. The spinal cord might be open. So something like spina bifida, a myelomeningocele might occur. Okay, so folic acid is number 1. When a client comes to our office the first time and she thinks she's pregnant, that's her reason for making an appointment to see us. She has usually certain symptoms that she's experienced, and we are making presumptions that she's pregnant based on some of her experience: nausea and vomiting, fatigue, sore breast, amenorrhea, the things that she is experiencing. It's not anything that we can measure or necessarily see, but and those are called presumptive signs. Nagel's rule: first day, the last menstrual period, you got to go back 3 months, add 7 days, and then a year. And you don't have to do it in that order. You can start with add a year, add 7 days, and then go back 3 months. It doesn't matter what order you do it in, you're gonna come up with the same answer. So plus, back -3 plus 7 plus 1.
I have a question about the first question for when it implants in the uterus. Would you say it was between 5 and 7 days?
No, it's usually between 7 and 10 days.
7 and 10. Okay, thank you.
Mhm, mhm. 7, 10 days after fertilization.
Yeah.
Okay. So some women during that first she thinks she's having a period when actually it's implantation bleeding. That's super, super early in the pregnancy. She might not even know she's pregnant yet. Okay.
Okay.
Okay. If it occurs later on, if she's 14 weeks pregnant, she starts bleeding, what could be occurring?
Detachment or a miscarriage.
Yeah, spontaneous abortion. Yeah. Or she might have a very low-lying placenta.
Okay.
Okay, so we'll talk about that in week 5. All right. Any other questions about the quiz? Now, the math was fairly simple. If you had trouble with the math, you definitely need to hang on after class today, and we need to go over it. Okay, so if you missed the math, did anyone feel like they ran out of time? No? Good, good. Yeah. I thought it was fairly straightforward. It wasn't a difficult quiz. So if you missed if you got a 7 or less, you need to prepare maybe a little better. But a 7 is a pretty good, 7 above, pretty good score for the very first quiz in this class when you had no idea what to expect.
Yeah.
And some of those questions were piddly, if you know what I mean. Implantate, when does it implant? You probably won't see that question again. I don't know for sure, but still you need to know the embryology, the basics that I told you about in that form. Okay. So when we talk about high risk, let's go over again how we screen for their very first pregnancy. When they come into the office, what is it about their background that makes them high risk? Let's see. And some other information.
Obesity, heart disease,
Yeah,
lack
yep, all
of
those diseases.
incomes, low incomes, and,
Yeah.
and no keeping the prenatal visit or no assisting.
Right now I'm hunting for my Zoom. Let me pull this over here. The more technology we have, the more complicated it becomes.
Mhm.
Yeah. All right. Everybody got their pens and papers ready to go to take some notes? Do you all know now where all these documents are found? Okay. So this one I'm showing you, the high-risk pregnancy indicators. I added some stuff to this since I gave it to you. So that means you got to watch the recording, okay? Because I wanted to pull up some new things. So we've talked a little bit about biophysical, the background from the mother of the fetus, okay? The development, other, the things that could happen during the pregnancy, psychosocial behaviors, kind of lifestyle a woman has, long-term history of depression is going to affect the pregnancy. Socio-demographic, social, where does she live? Does she work? Or is she an immigrant? And then environmental factors. Really important information because the way our world is, we don't have a melting pot in this country, and I don't ever think we need a melting pot. We all need to be our own selves and follow our own cultures and values and learn to get along, okay? So some of those biophysical, nutrition, diabetes, hypertension, chronic illnesses affect whether a pregnancy is going to go well or not, and the fetus will be healthy. Okay. Emotional situations, maybe some abuse, not feeling support from family, or maybe an adolescent, low income. Who was it that brought that up? I know who you are. I gotta think of your first name. I can remember your last name, which is so funny. Who brought that up? Oh, Mabel. Yeah,
Waves.
Mabel brought that up. Yeah, yeah. Do you know what is meant by a third world country?
They're not as advanced as us.
Okay. Do you know what kind of we call them now instead of third world?
No, I don't.
Developing. Whoops. Countries is what we call them now. Because we don't want to think of them as being hidden in the corner. We want to think of them as they're developing and, you know, in resources and education and the support that the rest of the world provide for them. So always think of them as developing countries. And you might think of one can you think of a particular developing country?
Mm,
The Middle East.
Asian,
Okay, some Asian countries, maybe,
African,
like some African countries for sure. Sudan. Sudan is they've got another uprising. It seems like people that live in Sudan are always at war with one another. They're considered a developing country. They don't have the resources. So if you have a woman that becomes pregnant and she's living in Sudan, there is a lot of things already going against her. Okay. All right. Hazards in the workplace. You know, textile factories, people that work in textile factories their whole life, they're at risk for bladder cancer. So we think of exposures at work. So is our client working in a factory? Or she could be an anesthetist and she's around a lot of anesthetic gases. Okay, radiation. And then viral pandemics. We know what that's about. I recently read an article, but they're recognizing now some of the problems with pregnant mothers. As doesn't matter what time of the pregnancy, if they contract COVID, if they've not been vaccinated, and even if they have, if they contract it, then the placenta will not filter out that virus. So we're seeing neuro damage in our in fetuses. And then of course pollution. What about the patient's perception? What is their outlook in life? What do they think about their pregnancy? You know, usually especially if it's the first pregnancy, unless it's been planned for years and years, sometimes they have some ambivalence. Do you know what that means? Ambivalence?
not sure.
Not sure.
Yeah.
They can be excited, but then again, they're not excited. They're kind of ambivalent about it. Okay. So it takes a while to adjust to the thought. Just fear of being a mother, the responsibility. It changes your whole life. So we talked last week a little bit about screening tests and stuff, about the pap test. You know, we do that beginning age 21. So if we have a client that comes in and she's never had a pap test and she's 21 or later, we might choose to do it. We don't always have to do it. Okay. But just know a pap test, she needs to be comfortable and we need to be able to do a good exam. So her bladder needs to be empty. Okay, it gets in the way. The bladder actually sits on top of the uterus. So if it's full, it's hard for us to not only see it in an ultrasound, but also to be able to palpate the abdomen. Okay, and we do cultures, and we'll go into this a little bit later. And then we're going to talk a little bit today about some blood work that we can do to screen for chromosomal disorders or neural tube defects. We can actually see some indications in the blood. Okay. And the other labs that we do, the Coombs test, lets us know if there's some RH incompatibility already in play. Reasons for doing an ultrasound in the first trimester. Well, she doesn't know when her last menstrual period was, or her periods are irregular. So we need to do an ultrasound to find out how far along she is. Or maybe we're suspecting she has twins. Or maybe she's having a lot of pain, and we want to make sure that that pregnancy is in the uterus and not in the fallopian tube. Obesity. She's 12 weeks. She's coming in for her first visit. I can't hear fetal heart tones. Okay, so we need an ultrasound because we should be able to see and hear baby's heartbeat at 12 weeks. So remember that uterus about 12 weeks is when it's large enough now. The fetus is a little more than an inch big. So that uterus should be stowing up behind the pubic bone, so we should be able to press on her lower abdomen and feel the top of that uterus at 12 weeks. And then reasons we do ultrasounds later in the pregnancy, the second and the third trimesters, are to check on fetal well-being. We want to check, make sure there's plenty of amniotic fluid. The baby is able to grow. We can measure growth every 3 weeks. We can measure growth. Where is the placenta? Is the cervix closed? What position and what lie is the baby in? Okay. And then if we have abnormal blood tests, we're going to do an ultrasound to follow up. And amniocentesis is going into the belly, into the uterus, and drawing some amniotic fluid. Okay, and there's risk associated. It's an invasive procedure, so we need an informed consent. So the risk associated with that then are for mother, bleeding or bleeding from the placenta, the fetal maternal unit, the placenta, bleeding, infection. You might cause labor or damage to mother's bladder or her intestines. These are done under ultrasound nowadays, so you can see what you're doing. Okay. Oh, and then risk for the fetus when you're going in there to draw some fluid, you could cause death, bleeding, stimulate labor, hemorrhaging, infections, injury to the fetus. And then we do the ultrasound. So I did find, and these are the new slides, a very short video on amniocentesis. And this is a great video. It's really short, so you can watch it and learn from it. Sometimes this is the best way. You just click on the arrow and it should show up. There it is. So it's only 4 minutes, okay? So it's good old YouTube. What would we do without it? Synthesis. And then here is one. This one is on the stress test. I didn't mean to put amniocentesis. This is the non-stress test, I believe. And these are the amniocentesis, like I said, we can do it early if we suspect a chromosomal defect, or we can do it later in the pregnancy for lung maturity. But the non-stress test we do later to check for fetal well-being. So that's a great video too. And then here's the contraction stress test that you can watch, the difference between the two. Okay. So the non-stress test tells us that the baby when the baby's moving in the mother's belly, the heart rate will stay caught up with it. In other words, when you walk faster, your heart rate goes up because you need more oxygen to your tissues, for your muscles. Okay. When a baby moves in utero, the heart rate needs to go up because he needs more oxygen. Okay. So when we do the non-stress test, we're just watching the heart rate go up when the baby moves. And it's just an indication that baby is being oxygenated well. Okay. And it, like, if a mother comes in, she's 32 weeks, or she calls the office and says she doesn't feel like her baby is moving too much, we could do a non-stress test just to make sure the baby is doing okay. We also will do an ultrasound. Okay. Whereas a contraction stress test, we are causing contractions, and we want to see how well baby would do during labor. And we're looking for the baby's heart rate to drop. So we can talk about that in more detail next week when we're talking about what a contraction is, what do we see on a fetal monitor during labor. And then fetal kick counts is another thing we do late in pregnancy. Once again, if that client calls the office and says she hasn't felt her baby moving, we teach her how to monitor baby movement. She has to pay attention. Okay. It's very valuable. There's no standard amount of movement out there, but just a change in pattern. Okay, questions about this PowerPoint. I will re-upload it. All the PowerPoints in the documents that I send your way are in the announcements. Go to the announcements in your module, on Canvas, and go to week 2. Okay, that's where all of week 2 information is. Okay, I will replace this one, okay, for you. So give me some time after class, I'll get it done. So fetal kick counts, then we want her to be aware of movement. And it's good to hear that the baby's moving 10 times every hour. Okay. And if she's used to feeling baby a lot during the day, if she's 30 weeks, 32, 34 weeks pregnant, she's used to feeling the baby a lot. And then she doesn't seem like she's feeling it as much anymore. We might just give her a little education. Sit down and rest for a while and count for an hour. See how many times baby is moving. And that'll give her an idea if things are going right. Okay. If there's any doubt, we'd have her come into the office. So that's what fetal kick counts are. Okay. So if we have our high risk or our adolescent, we have to monitor them very carefully during pregnancy. So, at the beginning, it's important for education, nutrition, medications, testing. And then as the baby grows, we want to monitor that fetus for growth and well-being. Okay, so we tend to do a lot more ultrasounds after 24 weeks. We tend to, for a high risk, we might do an ultrasound every 3 weeks, or more often if it's a diabetic or a high risk. Our adolescent teenagers, I keep coming back to them because it seems like things make sense when I describe it to you in that manner. So if I have a 17-year-old and she's pregnant, she's at risk because she's still growing. We're concerned about her nutrition. We want her to gain weight. We want to know that that baby's thriving. So we're going to do ultrasounds to monitor fetal growth. Okay. And if the amniotic fluid around that baby begins to drop, not as much fluid, then we are concerned. So we're going to monitor the fluid throughout her pregnancy. And we're educating mom along the way. So you can see how important prenatal appointments are to keep. Just because she might have survived a previous pregnancy and all went well, don't assume that the next pregnancy is going to go well. I had a client show up at 37 weeks pregnancy for the very first time. She said, I didn't have any trouble with my first pregnancy. And so she got no testing, no nothing. And it's hard to determine how far along she actually is unless she knows exactly when her last period was. And then, of course, she delivered her baby the following week. Okay. Okay, might not be something you know yet, but you'll learn it. Okay. So this is a question about amniotic fluid. It's important, and we're going to talk about amniotic fluid. We need all that fluid around that baby. Okay. It's very important. If there's not enough, it's called oligohydramnios or low volume. Okay. Usually it's an indication of something. So knowing that amniotic fluid is produced by the fetal lungs produce fluid. Okay, so it surrounds the baby. The fetal bladder, the fetal kidneys produce urine. The bladder excretes it in utero. So the amniotic fluid is made up of fetal urine and amniotic fluid and fetal lung fluid, plus some other things, mother's blood. Okay, so if we notice that the amount of amniotic fluid is dropping, what kind of fetal anomaly or abnormal structure could be going on?
Is it renal?
Renal.
Renal, yeah, the kidneys. Sometimes if the kidneys are not functioning well, okay, you might see a drop in fluid. Yeah, very good. Any questions about any of this? Let's see. Okay. Shayna, you found it, but it's not updated yet. Okay. So I will get it updated. This PowerPoint. Okay. So we are going to cover some more of this stuff. Let's see. What else do I have? Yes. So let's start with this. And we're going to practice some of this today. Another chat question. Feel free just to ask questions. You don't have to put it in the chat. Just shout it out, okay? That way I don't have to keep stopping and looking at the chat. Okay. So I have this document I made with pictures. I gave this to you as well. So some terms that you need to be familiar with. Prima gravida. So gravida is a pregnancy, okay? Paris means, or parity means a pregnancy that was delivered after 20 weeks. So a client with her very first pregnancy, she's a prima gravida because this is number one. Primi means first, okay? Nulli means none. She's not had any pregnancies that reached 20 weeks. So she's nulliparous, okay? Her very first pregnancy. And then a client, the next picture down, a multigravida means she's become pregnant 2 or more times. Okay. So prima para means someone who has only delivered one baby past 20 weeks. Okay. So in this picture, she's been pregnant twice. If you just look at this picture, she's pregnant currently, and then she has a little girl. So this little girl is her first parity, her first delivery past 20 weeks. And but she's a gravida too. Okay. So you'll understand this because we're going to work on this. Okay. And then multigravida and multipara means she has had 2 or more pregnancies and she's delivered 2 or more of those babies past 20 weeks. 20 weeks is the age of viability. Okay. And if we have a client that's a multigravida, she's been pregnant many times, but she's never carried a pregnancy past 20 weeks. She's also a nulliparous woman. Okay. In other words, she's had 3 abortions. She had a blood disorder. So she lost 3 pregnancies. And now she's pregnant for the 4th time. She's never been able to deliver any babies. Okay. All right, just some pictures to work on. Let's see here. Okay. Let's talk about, we'll go through this PowerPoint. Well, I don't know if we'll get through all of it because I want you to have a break pretty soon. So this is a picture of a what?
DNA. Chromosome.
Chromosome.
Chromosome. It's a chromosome. Yeah, it's a chromosome, and inside the chromosome, DNA, which make up the genes. Okay, genes. Just to give you a pictorial, we're going to talk a little bit about anatomy. So remember our picture?
Yes, ma'am.
So we have fertilization, zygote, eventually becomes a morula, and then a blastocyst. And blastocyst then will implant, and this picture says 6 days, but we're teaching you 7 to 10 days, okay? And then that blastocyst will become an embryo at 15 days. Okay, so a little over 2 weeks. So you had your first assignment as an ectopic pregnancy. It's high risk. Usually an ectopic pregnancy is a zygote that does not move through the tube. It gets stuck in the tube.
Sorry.
That's why it's outside of the uterus. So it's ectopic. Okay. It will not survive. It will cause a rupture of the tube. It's very, very painful. And there's a risk if the tube ruptures, that mother could bleed internally quite a bit. So if you have a client in her first trimester and she calls the office and tell you she's really, really hurting, what do we need to do?
Get her to come in.
And what would you do then?
An ultrasound.
An
Yeah.
ultrasound. Yeah, we want to see where that baby is. We want to verify that embryo is in the uterus. Okay. If it isn't, then we have to, well, we know mifepristone is off the market right now, but we can do other things. If she's bleeding a lot, we have to do surgery, okay, and remove it. Okay, so refresher, when an egg and a sperm unite and fertilization occurs, it becomes a zygote, okay? So each zygote has a full set of chromosomes. So the sperm egg and the egg, okay, they bring in half of the number of chromosomes that's needed and one sex cell. So if the sperm has an X chromosome in it, we're going to have a female. If the sperm has a Y chromosome, it's going to be a male child. Okay, so the sperm determines the sex of the fetus or the embryo, the zygote. So when we talk about chromosomes, every
I
human
have a question real
has,
quick.
yes,
Sorry, on that last slide, the picture says 22, 22, 23. Oh, never mind. Okay, I get it now. Just kidding.
that's okay. Sometimes it takes a while for it to click. So for example, okay, this is a male. Do you see down here where that green arrow is?
Yes, ma'am.
There's 2 sex chromosomes there. One of them's a Y. So this is a male. So if we got a piece of tissue from a fetus and we did a karyotype, looking at the chromosomes, we would look for the sex chromosomes. So there is a cell-free DNA blood test that we can do. Insurance doesn't normally cover it. And we can recognize these two chromosomes. Okay, so every human normally has 22 pairs plus a pair of sex chromosomes, 22 autosomes and one pair of sex chromosomes. Okay, they have pairs, each one has two. Okay, that's the male, and then this would be the female, the two X's down here. Okay. There are certain situations when we do alpha fetoprotein testing, we might find out that there is extra alpha fetoprotein, which could indicate a chromosomal defect. So let me talk to you about, there's different kinds of, and keep in mind the picture that I showed you of the chromosomes. Okay. So Down syndrome, you see this picture? So this is a male, right? XY. So this is a male and it's got all the 22 autosomes here. But if you look at autosome number 21, there are 3 of them instead of 2. So there's an extra autosome here. So this is what a person with Down syndrome, this is their karyotype. In other words, this is what they have in their cells. Maybe not every cell, depends on the severity. So there's an extra chromosome and it causes defects, heart defects, emotional defects. These people tend not to live as long, 30s, 40s. And then they have some other characteristics. They tend to have thick neck, okay? Maybe a little cognitive delay, certainly a judgment delay. They have what's called simian creases in their hands. Okay, their legs are shorter, their arms tend to be shorter. So that is Down syndrome. Okay. And there are other, and I didn't get pictures of Turner syndrome and Klinefelter syndrome. I know that you don't have to know these terms for any of the OB exams. I don't know about the HESI, but for the OB exams, no. But if you look at these, and this is Klinefelter, and I copied these. So Turner syndrome is missing one, missing a sex. So in this karyotype, the picture, she had all her autosomes are normal, but her X chromosome, her sex chromosome, she only has one X. She doesn't have a Y, she doesn't have a second X. She just has one X, she's missing one. So it's a mono, meaning one. Okay, so she has 22 autosomes and one sex chromosome. Women with Turner are short, sexual immaturity, which makes sense, oftentimes webbed necking, and some infertility. Klinefelter is the male, okay? He has 22 autosomes, but he has an extra sex chromosome. He has the extra X, okay? Instead of XY, he has XXY. And this is also called a trisomy. Okay, so Klinefelter men are taller than average, infertile, small testes, small penis, poor muscle tone, poor language development. Okay, infertility for sure. So those are just 3 abnormalities I mentioned to you. So remember, it's the autosomes and either an extra autosome on 21, 18, or 13. Those are all trisomies, or normal autosomes and a missing X, or 2 X's and a Y. So the 13th chromosome or autosome is also a trisomy because there's an extra 13. And it's Edwards syndrome. And then number 18. So these two abnormality chromosomal amounts don't usually survive. Okay. If they do, it's not very long. Okay. Severe defects. Okay. And then, however, chromosome, people with Down syndrome that have the extra 21, they tend to live a lot longer and survive. So if a woman is 35 years old or older, she has 35-year-old eggs. Okay. They're not renewed. Okay. So they're older eggs. So she has a risk for having a baby with Down syndrome if she's 35 or older and gets pregnant. If she's 49 and gets pregnant, it's 1 in every 10 conceptions she's going to deliver Down syndrome. So the way that you have your chromosomes and your genes inside of them, the way that I have mine comes from our parents, right? Sperm and an egg unite is from your parents, okay? And the way it's called an inheritance. I inherited certain genes. Some of them are good, some of them are bad. Some of them will be a recessive type gene or a dominant type gene. For this class, we're only going to really talk about the recessive genes, okay, for the sake of simplicity, okay? If the mother, if you, let's say if our client and the father of the baby have defective gene, a specific one, a gene for cystic fibrosis, okay, they can pass it on, right, to their children. Okay, if they both have the gene for cystic fibrosis or sickle cell, maybe fetal ketonuria or galactosemia, all these diseases in this list, if they each of them have one of those cells, so the pair of them have to have it. If they do, there's a 1 in 4 chance that one child, this one right here, this red one, is going to have the disease. Okay, neither mother or father have the disease. They just carry the gene for the disease. Okay, but one of their children out of every 4 is going to have the disease. 2 of the children out of 4, in other words, half of them are going to be a carrier, just like mom and dad. And 1 out of 4 won't have the gene at all. Okay, so this is called recessive. Okay, autosomal recessive. It's recessive because only 1 in 4, and because both parents have to have the pair. We need 2 pairs. Okay. And we can draw blood when mother comes in for the very first visit. We can draw her blood and determine if she is a carrier for the cystic fibrosis or the sickle cell gene. If she is, then we need to test father, if that's what she wants. Okay, so this is called carrier screen because we're seeing what abnormal genes she carries. And this is just an explanation of the dominant. Okay, so if a client has a gene that's a dominant gene, like this list, then whether the other partner has it or not, it doesn't matter because that gene is dominant. So that half of the children between this couple are going to have the disease. So let's, for example, von Willebrand, it's a bleeding disorder. So if the father in this picture, it's the father that has von Willebrand. So he has the disease. So half of his children, okay, 2 out of every 4 are going to carry that disease. One daughter could have the gene but not be affected. Actually, this is this should be, these 2 black on the bottom should be unaffected. This is a typo in this picture. Okay, the 2 black ones are unaffected, they're healthy. Okay, the other 2 have the disease because it's a dominant gene. So sometimes it's the genetic transmissions, in other words, inheriting them from parents. But sometimes we're exposed to certain environmental pollutants that can alter genes. And they're studying the COVID virus now, the SARS-2 virus, and they're finding that some genes are being altered by the virus. Okay, so there's a lot of reasons that causes congenital anomalies or defective genes. Okay, so cleft lip and palate, certain medications, congenital heart disease. You don't have to know this. Congenital heart disease from rubella infection during pregnancy, or diabetes, hyperglycemia during pregnancy. Neural tube defects could be inadequate folic acid. So these are just a group of newborn diagnoses that could be a cause of just a genetic inheritance plus environmental exposure. And then non-genetic, they go into all this. A teratogen, human teratogen is usually something that causes damage to an embryo. Drugs, we think mainly of drugs. Okay, malnutrition affects brain development of an embryo. Okay, we talked a little about, I gave you the document on embryology. Remember, 2 weeks after conception to week 8. So 15 days to week 8, embryology. All the organs are being, the structures of the embryo are being put in place. And so beginning week 9, we have a fetus with all parts completed, okay? The heart actually begins to beat at week 3. We can't see it on an ultrasound until usually week 6 or 7. And we can't hear it with our Doppler until usually week 9, okay? So here's just an ultrasound. This is a 6-7 week embryo. We can see all the parts that we would typically see at this point. We might not see a heartbeat yet. If we did an ultrasound on our client to determine how far along they were, and we saw this, we could measure the crown to the rump and determine the gestational age of the pregnancy. And we might see the yolk sac, and we might see the amniotic fluid here, but we might not see the heartbeat. So we would have her come back the following week, and hopefully we would see the heart beating. Okay, so the amniotic fluid. Do you want to take a quick break? Okay,
Yeah.
it's 8 after. How about 20 after? Okay, so that's 12 minutes. I'll give you 12 minutes, and then we'll start off with the different parts of the pregnancy.
You're muted.
All right, let's talk about our parts of the pregnancy. We said a mother. Okay, we're going to go into mother after we're finished this. So amniotic fluid, like I said earlier, it's produced shortly after that blastocyst is implanted. It comes from maternal plasma initially. And then as that embryo develops and grows and becomes a fetus, it's then produced by the fetal lungs and the fetal kidneys. So remember, organogenesis, or the embryology period, is the first 8 weeks when all the organs are being put into place. starting at week 9, we have a fetus and everything's in place at this time. So the amniotic fluid grows and continues to grow as the baby gets larger to meet the needs of the fetus. Okay. The purpose of amniotic fluid is just to absorb shock. So it's buoyant in the water. Okay. It also keeps the baby at the same temperature as the blood. In other words, it's regulating or maintaining a good ambient temperature. Some immunoglobulin protection, but not much. And when we have plenty of fluid around the baby, it just allows that baby to grow and to stretch arms and legs. It keeps the umbilical cord buoyant because we don't want anything to squeeze that cord. Okay, it needs to be free floating. Okay, so it keeps it from getting entangled and knotted up. Although you do see babies born with knots in their umbilical cord. They do some acrobats towards the end of their pregnancy. Okay, so at 9 weeks, a baby's about 1 inch. And this is when we can begin to hear the heartbeat through the abdominal wall. Okay. You can see in this picture of this ultrasound that the baby's ears are there, the eyes and the nose and the mouth, although you can't see it. Fingers and toes are there. Okay, so everything is there. It's going to mature from this point on. And the nervous system and the heart have already been beating. The umbilical cord itself, I call it the lifeline. Okay, it's what connects the placenta, which is providing everything that baby needs, to the fetus. Okay, it has 2 small arteries in it, and it has 1 large vein. Okay, and then it's in that cord, the vessels are inside the umbilical cord, and they're covered with a substance called Wharton's jelly, and it helps keep those vessels moist and protected from trauma. Okay, that's all the umbilical cord is for. It doesn't have any other function except to house the vessels for the baby. Okay, so the vein, the large purple umbilical vein, carries oxygenated blood from mother's blood, okay, from the interface between mother and the baby. The 2 small arteries are carrying that deoxygenated blood away from the fetus back to the placenta. Okay, so they're actually connecting the 2. The placenta is the major organ of pregnancy. Without a placenta, we can't provide what a fetus needs. Okay, so this is where all the action takes place. The placenta is interfacing, you might say, not connected. There's no mixing of blood between baby and mother. It's a connection where the fetal vessels and the maternal vessels are like this. There's only a cell layer between them, so that oxygen can be transported across from mother's to fetal vessel, okay, to the fetal vessels. And then the carbon dioxide can be moved from the fetal vessels to the maternal vessels. Okay, same thing with nutrition. Nutrition comes from maternal to the fetus, and the metabolic waste returns via the umbilical arteries to the mother. Okay, so you can see how important it would be for our big uterus to be full of blood, so we can provide adequate oxygenated blood and nutrition to the fetus, to the placenta, to the fetus. Okay, so you really have to kind of study this picture on the bottom here. This is the mom's side. So this is the inside of the uterus, you might say. And the endometrial layer. And these are blood vessels that are coming in And the space between mother's vessels and the fetal umbilical vein and arteries is called the intervillous space. And this is where all those blood vessels are like this. Okay, so the exchanges could take place. So it's really important for that endometrial, which is the mother's vessels, to be full of blood and relaxed. So we need a relaxed uterus. We need dilated, full capacity blood vessels to reach the placenta. So if mother has low blood pressure, it diminishes the blood flow to the fetus. If she has high blood pressure, it diminishes blood flow. If she has low blood volume, it diminishes blood flow. If she's smoking cigarettes, nicotine, it diminishes blood flow. So smaller babies, okay? So placental health relies on good uterine blood flow and blood pressure and good nutrition, okay? So the placenta is mature at 12 weeks. And this is where the progesterone comes from beginning 12 weeks. We need progesterone, remember, to maintain the pregnancy, okay? So the placenta begins to produce progesterone at this time. Prior to that, it was coming from what's called a corpus luteum, okay? All right. So that's your placenta. It's called the exchange organ. And then the blood flow through the fetal heart. Now, don't make this any more complicated than what it is. The underlying premise is that fetal lungs are not functional. We don't need them to work yet, okay? Because the oxygen is already in the baby's lungs from mother, okay? So we don't need to oxygenate the lungs from the baby's lungs. It comes into the baby from the umbilical cord already oxygenated. The majority of the blood will come in to the inferior vena cava through the right atrium. So the blood pressure within the right atrium and the left atrium is low, and it's higher in the right atrium than it is in the left atrium. So it draws the blood into the left atrium. A lot of the blood is bypassing the right ventricle. So remember, we don't need to go to the lungs, okay? So we're going to go through what's called a foramen ovale. Then it goes to the left ventricle, the left atria, the left ventricle, and the aorta, and then out, okay, to the rest of the body. The blood that does come in from the superior vena cava, it goes into the right ventricle and to the pulmonary artery. But not much of it is going to the lungs. It's bypassing the lungs. And this is what we call the excuse me, ductus arteriosus. Okay, there's a duct there that shunts the blood away from the lungs. And then it goes into the aorta as well. Okay. So remember, the lungs are not being used for perfusion. So we have to bypass the lungs. So we have a different route of blood flow than the regular adult heart. Okay, so now you just delivered a baby, your very first one as a labor and delivery nurse, and you're excited. So one of the first things you do is dry your baby, stimulate your baby, put baby on mother's chest. Okay, and we're going to very shortly look at and clamp the cord, and we're going to look to see how many vessels are in that cord. Because when we cut it, we can see a cross section. 3 vessels. Okay, so we have 3 vessels, right? Normally, we should see 3 vessels. So what else? 2 arteries and 1 vein. Okay. Every once in a while, we will see 2 vessels. So we have a 2-vessel cord. Sometimes it's a problem, sometimes it isn't. We just keep an eye on that baby to make sure that baby is growing.
Does that mean like you have like a blood clot or something? If you have 2
No.
cords or?
No, No,
Okay.
doesn't mean anything about blood clotting. Okay, so you have a client that's asking you, how can the baby breathe when it's surrounded by amniotic fluid? How do you respond to your client?
They're breathing through the placenta.
Okay, that's one way of saying it. Yep. They don't need to breathe.
Right.
Their blood that's coming to them is already has oxygen. Sometimes they still don't understand it, but it's not an easy concept. We're so used to, having to breathe, right? We breathe to oxygenate our blood. Okay, true or false? The placenta, it's a temporary organ.
True.
Yeah. It's formed during a pregnancy, and once that pregnancy is over, it's gone. Mhm. So it begins to calcify late in the third trimester. In other words, it's getting old, it's not as efficient. Okay, that's why it's dangerous to go beyond 42 weeks in a pregnancy, because that baby probably isn't getting everything it needs. Okay, so the placenta connects to the maternal blood vessels, connects to the maternal blood vessels for oxygen and nutrients.
True.
True, true. There's a high pressure flow from maternal vessels to the placenta.
True.
No, we want low flow. We want low flow.
Relax.
We want a lot. But we want those vessels, those maternal vessels, to be dilated, which they are. Progesterone helps them to open up, to hold more blood. So it's a lower flow going into the placenta. So placenta is dependent upon adequate blood flow and pressure from the uterus.
True.
True. Placenta filters out toxins, including alcohol, from the mother's blood.
False.
Oh,
False.
It does filter, but not everything, right?
Right, right. It might filter some things. But generally, if mother has sepsis or an infection, a systemic infection, the fetus will get it too. If she has a virus, the fetus is going to get it too. If she's drinking alcohol, the fetus gets alcohol too. Okay. Okay, this is just a little cheat sheet for you, or to let you know, you need to know these things, how to go from units to milliunits, grams to milligrams, milliliters to liters. Okay, you're just moving your decimal point. So 20 units is 20,000 milliunits. And you probably never heard of milliunits. There is one drug, it's a hormone that we give for contractions, and that's oxytocin, and it's prescribed in milliunits. Okay, the bag that you get from the pharmacy is going to have units. It's going to be labeled 40 units in 1,000 or whatever, but it's prescribed in milliunits per minute. So there's several steps to go through to calculate. I don't want you to feel overwhelmed. It's not as complicated if you follow certain steps. Step 1, step 2, step 3, learning how to do it in that way, and always following the steps, you should calculate correctly. Okay. 400 milliunits is 0.4 units. Rounding, if you and you will probably have a question on the exam asking you to not only calculate, but then round your answer to the 10th place or the 100th place. So you have to remember how to round. So I gave you some examples. Rounding to the 10th place would be 2.39. Rounded up would be 2.4. So that 100th place, that 9, if that's a 5 or greater, we round up, okay, to 2.4. And then the 100th place would be 5.56. So we're going to round it to 5.656, 5.6, because this is right here is a 5. Or actually, this right here is a 6. Okay, so that's how you round. So if you do a wonderful calculation and got it all perfect, but then you didn't round when it asked you to, then you can't get credit for all your hard work. Okay. And then you need to know that 30 mLs is an ounce. So you need to convert, if you're going to add up a client's intake, you're going to add up by ml. Okay. So you have to convert everything to an ml. So a cup of orange juice would be 240 ml. A half a cup would be 120. Okay. The term bolus. Now, on your OB calculations, at first you had a couple problems that talked about a bolus. So can anybody describe to me what is meant by a bolus?
A one-time dose.
Yep, a one-time dose. So it's usually a larger, it's a more concentrated in a smaller volume because we want to get it into the system to get that level high enough quickly, okay? So heparin, if you've got a client with a deep vein thrombosis, a blood clot, or maybe a blood clot in the brain, we want to get that heparin in there as quickly as we can. So we're going to do a bolus. And a lot of times it's an injection just into an IV port. Okay, it's not even a bag. It's right, you push it right into the IV cord or IV tubing at the port. And then we begin a continuous maintenance infusion. Okay. So on the OB calculations, there was one that required 7,200 units of heparin. Okay. We're not going to give it by the hour. We're not giving it volume. We're pulling it out of a syringe. Okay. Not out of a bag. So heparin comes in syringes, like there's a 10,000 unit syringe. There's a 5,000 unit syringe. So if you needed 7,200 units, you're going to get a syringe that has 10,000 units in it and calculate how much of that syringe you need and waste that or waste what you don't need. Okay. So we got to get it in and then we're going to calculate our maintenance dose. Any questions about that? I did fix that math video, by the way. So we want to go back and look at that. Okay. So let's go over these terms that I briefly threw at you earlier. Okay. Gravidity. It's a pregnancy. Okay. A gravidity is a pregnancy. A gravid woman is a pregnant woman. Okay. A pregnant woman. Nulli gravida means a woman who has never been pregnant. Nulli means none. Primi gravida means a woman who's pregnant and it's her very first conception. Multigravida means she has conceived 2 or more times. No matter what the outcome is on the gravid, it's still considered gravida. Okay. A parity is that gravidity that reached 20 weeks of pregnancy and was delivered at some point beyond that. Okay. 20 weeks gestation is considered roughly the age of viability. In other words, if a baby is born at 20 weeks, it's extremely premature, but it's a parity. Okay. It is a parity pregnancy. Okay. So it's the pregnancy itself that we're looking at here, not the number of babies. So if we have a mother that delivers a baby at 22 weeks, it's a parity. She delivered the baby. Whether that baby survived or not, it's still considered a parity. Okay. A nulliparous woman, nullipara, she might have been pregnant 3 times, but she's never had a pregnancy that survived to the 20th week. Okay. She's never delivered a pregnancy that survived past 20 weeks. Nulliparous. Okay, so primipara, she has delivered her first pregnancy after 20 weeks. Her first time, she's delivered one after 20 weeks. A multipara means she's delivered 2 or more after 20 weeks. So remember, the term viability is the capacity to live outside of the uterus. So the threshold is usually 22 to 25 weeks. They're very premature babies, as you can imagine, okay? And their most vulnerability is the brain, okay? The cerebral blood vessels are very fragile. They bleed easily, okay? They're not completely developed. So if there is delivery after the fact, then we have to protect that. And there's certain things that we do. So a preterm baby is one who was born 20 weeks to 36 weeks and 6 days. That baby is considered full term at 37 weeks to 41 weeks and 6 days. So a pregnancy that goes to 42 weeks is considered a post-term. That placenta is getting old at 42 weeks. And this just describes it in another way. So we have this categorization that we do. And it's called the GP status or the GTPAL. And so we assign numbers to each category. Okay. See, Haley, I don't see your head. You need to sit up and pay attention, okay? All right. And you need to remain on camera all the time. Thank you. So a term pregnancy. So GTPAL. So the G is the number of times a woman has conceived, no matter what the outcome was, when she got pregnant, how many times has she become pregnant? Okay. And then the TPAL are the outcomes for those pregnancies. So if she's G5, okay. The first pregnancy, was it a term baby? Was it a preterm? Was it an abortion? Or was it, yeah. And then how was it alive when it was born? Okay. So we're going to practice. All right. So the earliest biochemical marker, in other words, when we draw blood or check a urine, we can find human chorionic gonadotropin if she's pregnant, okay? As early as 7 days after ovulation, if there's been fertilization, okay? 7 days. We can find HCG levels beginning to climb, and they double every day, okay? So we determined that we do have a pregnant woman. So we need to know, when is she going to deliver her baby? What is the due date? So we use what's called Nagel's rule. Okay. So we start with the first day of her last menstrual period. Okay. Let's say April 1st, 2022 was the very first day of her last period. Okay. So now we go back 3 months. So March, February, January. Okay, so January 1st. Now we're going to add 7 days. So January 8th. Now we're going to add a year. January 8th, 2023 is her due date. Okay, subtract 3 months, add 7 days, and add a year. So we have June 21st, 2021. Okay, that was the first day of her last menstrual period. Okay, so what's the first thing we need to do?
Change it 3 months, so it should be March 27, 2022.
March
Or
28th,
March 28th, sorry, +7.
2022. Correct. What about March 4th? Somebody else. So March, February, January, December of 21. Okay, December 4th. So add 7 days, December 11th of 2022.
It should be
Or
January,
I'm
right?
sorry, 2023.
Okay, yeah. December.
Here, Weston.
Yes. Okay, then what about the last one?
January 9, 20,
Okay, so January 9th,
23.
2023. Good, good. So you just have to memorize it. 371. Okay, presumptive symptoms of pregnancy. So we're done talking about the fetus. We're talking about mother now. Okay. So the things that she feels. Okay, we have our client Abby coming into the office, and we're going to talk about Abby when we get done these slides. So Abby's coming into the office, and she says she thinks she's pregnant because she's so tired. She's fatigued all the time. She's throwing up, and she's missed her period. Amenorrhea. Her breasts are tender. That's caused by progesterone. And if she's far enough along, if she's delayed and she's 16 or 18 weeks pregnant, she's feeling the baby move. Hopefully that's not the case. But quickening is a presumption of pregnancy. So we're presuming she's pregnant at this point. We don't know for sure, but she's telling us she's got some things going on, some symptoms. So we're presuming, okay? We're making an assumption ahead of time that she's pregnant. So once we talk to her and get her clinical history, her vital signs, we're going to do a physical exam. And there's some things that we can see on a physical exam that can tell us, yep, she's probably pregnant. And so you as a nurse or me as a provider, when I do my exam, I'm noticing some things. I'm noticing when I do a speculum exam, when I'm looking at her cervix, okay? I've got my speculum in there and I got my cervix visualized. It's got a blue tint to it. So does the vaginal tissue. It's all bluish. And this is the dilated blood vessels, very vascular. Okay, that's why it's just, this blue tint. And this is called Chadwick's sign. So when I see this, I'm like, yeah, she's probably pregnant. Okay. If we do an HCG test in the office and it comes back as 2 lines, she's probably pregnant. But sometimes that's a false positive. Okay? If she's taking certain medications, it can turn it to a positive even when she's not pregnant. Okay.
Now,
And then
sorry, excuse me. The earliest that you can see Chadwick's is at 6 to 8 weeks.
probably, I would be my guess. I would have to say, yeah, 6 to 8 weeks, probably at least 8 weeks.
Okay,
Yeah,
because
because it takes, yeah.
this will be
What?
something that we perform before like an ultrasound, correct?
Yes. Yeah.
Okay.
Yeah, it's a physical exam that we do on all pregnant women. That initial appointment, we need to do a physical exam, head to toe. We usually check thyroid, do a thyroid exam, heart, lung exam, abdomen exam, pelvic exam, or abdomen and lower abdomen, and then a bimanual exam using 2 hands, doing palpation. We do a speculum exam and do cultures, or a pap smear and extremities. Okay, so probable signs would be Chadwick's, that's the blue. Okay, ballottement is something I've never been able to do. When you do a bimanual exam, and bimanual means using two hands. I've got my hand on top of her pelvis, and then I've got two fingers that I use to palpate the cervix. Okay, to palpate the cervix. And if I lightly tap up on the cervix, sometimes if she's far enough along, I can feel a little vibration from the fetus. Goodell sign is the cervix getting soft, and you can see that this, of course, you're not familiar with what a cervix looks like, but this cervix looks pregnant because it's very soft and it's got the mucus. This is part of what we call the operculum. The operculum is a mucus plug. Okay, somebody's got their phone on and they're on.
The good
the-
sound is usually a good sign, right?
Yeah, it's a good sign. It's soft, good and soft.
One of them, the Chad, is it the Chadwick sign? Not a good sign, right?
Chadwick's is good. Yeah, it's indication. These are all indications
Indications of pregnancy.
that she's pregnant. Yeah, she's probably pregnant if we see these things. Okay. If you do an exam, Thomas. Haley, do you have a question?
Yeah, so you can detect the mucus plug right away.
Not necessarily. Not necessarily. Because
Oh,
it has to grow. Yeah.
Okay.
And sometimes you don't see it. Okay.
Okay.
But in this picture. Hi. Hi.
But in that picture, that's what it would look like.
Yes.
Okay.
Yeah. Chadwick's is blue and it looks irregular. And that to me tells me it's soft. Okay. So Goodell is that it's soft, good and soft. Okay. And then there's another sign. There's two more actually. Hagar's sign. And so when I do my bimanual, and you can see in this picture where I have my hand on top and I'm palpating the uterus with my hand on the outside, and the inside, I've got the cervix and I'm feeling that area and it's soft. And the cervix will, or the uterus bends forward. And that's called McDonald's side. I don't have a picture of that here. Your book has really good pictures of this too, so you can look in your book. You'll have to know you'll have to recognize the difference between presumptive, the client, probable, me, positive, the machines. Okay. The client, the examiner, and then machines. Okay. So we can tell our client absolutely for sure she is pregnant because we see it on an ultrasound or we hear fetal heart tones with a Doppler. Or if I put my hands on her belly and she's far enough along and I feel movement, I can tell her for sure she's pregnant. That's the only ways we can know for sure that she's pregnant. Okay, so a positive HCG could be a false positive. Okay, it could be something else that's causing it to turn to two lines. So we consider it probably, okay, not positively pregnant. So once again, going through them, you can look through these. See, I'm going to add this. I'm going to add McDonald's. And that's just the uterus flopping over. Okay. So we're going to talk about different changes in mothers' systems. Okay, let's start with the breast. So we know that the breasts become tender. They begin to enlarge. So progesterone makes them tender. Estrogen helps them to grow and develop. Okay, they're developing the lactiferous ducts, the ducts that will hold the milk. Okay, skin changes, the areola, that tissue around the nipple gets darker. Okay, the uterus grows. The uterus contains 1/6 total of maternal blood. So if she has, and I'm just going to say 6 liters, and she doesn't have that much, 6 liters of blood, okay, 1 whole liter would be in her uterus. Okay, so the uterus has a lot more blood during pregnancy than not. Okay, the uterus actually changes in size and shape and positioning as it grows. Okay, it's more relaxed, it doesn't contract as easily. Okay, so it's more relaxed during pregnancy, and that's progesterone doing that too. Okay, and then the uteral placental blood flow, the blood from the uterus to the placenta, is continuing to grow. Okay, the amount. Okay, normal to have a little bit of elevated white blood cells during pregnancy, especially in the urine. Okay. So that the breast, actually, those lactiferous ducts are actually mature and ready to function at 6 weeks in pregnancy. Okay, the breasts are much heavier. Okay, the milk is produced within those ducts by the hormone prolactin. So during pregnancy, prolactin levels slowly incline, but not a whole lot until the delivery, after delivery. Okay, estrogen and progesterone climb, both of them, during pregnancy. Okay, colostrum, that's the first product that's secreted from the breast. Sometimes it occurs during pregnancy, but usually once that baby is born, it's ready to go because the colostrum has nutrition for the newborn before the milk actually comes in. Okay.
Now, does the progesterone like block it until birth?
It's the estrogen that blocks it.
Estrogen. Okay.
Yeah. If you have high estrogen levels, the prolactin is low. Okay. That's why when a mother wants to breastfeed after delivery, we can't give her birth control with estrogen in it, or she won't produce milk. Okay. So what's the fundus?
Top of the uterus.
Yeah, it is the strong muscle of the uterus. That's what contracts when a client in labor has contractions. It's that very top portion that contracts and pulls up on the bottom part of the uterus. Okay, so the fundus is a good piece of data that we collect from our clients when they come in for their visits. So we're not going to be able to palpate that before 12 weeks. Okay, because it's still down behind the pubic bone. But once she reaches 12 weeks, we should feel a little bit of something there. Okay, and as that baby grows and the uterus grows, by the 20th week, it should be almost all the way up to the umbilicus. Okay, almost up there. So once it gets to the umbilicus, every week, it could be as much as 2 centimeters higher. So usually we can correlate where the fundus is as to the age of the pregnancy. So if we measure with a tape measure from her pubic bone to the top of the fundus, and we get 28 centimeters, we can guess that she is 28 weeks pregnant. So it correlates. Once we get to the 20th week, it begins to correlate with the week of gestation. So once again, estrogen and progesterone both cause growth. Okay, estrogen causes blood vessels, not only in the uterus and the placenta, to dilate a little bit and decrease the pressure, but also in the pelvis and in the legs, okay? And the arms, nose. Okay, so there's more blood flow everywhere. Because of the pooling of blood in the periphery too, blood pressure actually doesn't change because there's more volume, okay? So if the blood pressure is usually the same throughout pregnancy. Now, if she's obese or if she has a history of high blood pressure, it's going to be elevated, okay? Okay. Cardiovascular system, we've got a lot more plasma. You know, blood is made up of plasma, serum, and red blood cells. Okay. Those are the major contents of blood. Plasma is always more volume than the red blood cells. Okay. So during pregnancy, plasma will double. Okay. Now the red blood cells probably won't double, but it'll be close to it. So there's a dilution there that takes place. Okay. Because of the excess plasma. So if I got some blood from one of her veins and put it under a microscope and I'm looking at it and the red blood cells seem sparse, I'm thinking she's anemic when it's not really a true anemia. Okay. It's called dilutional anemia or physiological anemia because of the excess plasma. Okay. The heart rate increases during pregnancy. Hemodilution. Or dilutional anemia. So her hemoglobin usually drops a little bit. We are not concerned until it drops down to 10. At 10, then we consider her anemic. So we've got more blood and the heart beats faster. Therefore, cardiac output increases. The demands for blood, the demand for oxygen increases during pregnancy. So the heart works really hard during pregnancy. Okay, so it's really hard on a woman with heart disease to be pregnant. One other thing we know about the pregnant state is that women have a more susceptibility to blood clots. Her blood easily coagulates. So she's hypercoagulable, increased risk for blood clots. So what would you be teaching if you knew she's at risk for a deep vein thrombosis in her lower extremity? What could you teach her?
Ambulation, move around.
Absolutely. Maybe some TED hose, support stockings if she needs them, that would help. Yeah. So if she's going to ride in a car or fly in an airplane, every couple hours she needs to get up and walk around. Okay, move those legs. Usually most airlines will let you fly up to 36 weeks. If you look super gravid, you need to have a letter from your provider saying it's safe for you to fly. And that's not because of blood clots. It's because, there might not be anybody on that airplane that could help you if you go into labor. And you need to know where you're going. There's a provider available in case you do go into labor or have any kind of problem. Okay, so we have our client who's late in her pregnancy. She has, not necessarily super late, but she has a pretty good sized baby and lots of amniotic fluid, a huge uterus, and she's lying flat on her back. So vena cava or aorta caval syndrome. So you know that the vertebral column in the back, and then in front of that is the inferior vena cava and the descending aorta. And they bifurcate in the low back, right? Or just below the kidneys, kind of. So If we have a very gravid woman and she's laying flat on her back, like in this picture, and you've got that vena cava right there, what's happening? What's that baby in uterus doing?
Cutting off circulation.
Yeah, exactly. It's stopping the blood flow from the vena cava. So what happens is that vena cava no longer is delivering blood to the mother's brain, nor to the baby. So mother will probably feel lightheaded. So her blood pressure drops, hypotension. And when her blood pressure drops, the blood flow into the placenta drops. And the blood flow through the umbilical cord drops to the fetus. And then the fetus heart rate drops, called a deceleration. So what we need to do is what?
Change positions.
Yeah.
Yeah, get her off her back. Get her off her back. Get her on her left side. Okay. Her left side, because the vena cava is more towards the right side of the vertebral column. Okay. So get her on her left side. Okay. Get her just to roll up on her left side, and that usually resolves the problem. And so you want to be teaching her as she gets along in her pregnancy, not to spend a lot of time on her back, because we need to get her on her side. The respiratory system. So she doesn't breathe faster during pregnancy. She just breathes deeper. So she's like mildly hyperventilated, okay? Because she needs more oxygen in her blood. Her metabolic rate goes up. So she's going to need probably 300 more calories a day. Okay. The kidneys are working harder because they have a lot more blood to filter. Okay. She's more at risk for urinary tract infections during pregnancy, and we treat them. If a woman is not pregnant and we find E. coli in her urine, sometimes we'll just tell her drink a whole lot of fluids to flush it out, and usually that'll take care of it. But if she's pregnant, no, we need antibiotics because she's at risk. Skin changes. Know which ones are permanent, which ones are temporary. There's really only one permanent one. Does anybody know what it is?
Stretch marks.
Stretch marks, and they are called
Try something. Oh, yeah.
striae gravidarum. There it
Striae
is right there. Yeah, striae gravidarum. Stretch marks. They're permanent because the skin is stretched. You know, someone who gains a lot of weight can have stretch marks. Okay, they do fade and shrink. Okay, and it's a genetic thing. There's really not anything you can do to prevent it. I mean, you might be able to do a little something with lotions and stuff, but melasma, chlasma is just an increased pigmentation of the face. Melasma or chlasma, it doesn't matter. They both mean the same thing. So progesterone, remember how I've talked about it so much, what it does, all the functions that it does. So if we have a client that had trouble getting pregnant, we might give her some extra progesterone during the pregnancy to support the pregnancy, okay? Usually for the first 2 weeks or so. And then if she's had a history of a preterm birth, we might continue that progesterone farther along.
And that's a hormone that relaxes the smooth muscles, right?
Yes, sir. Yes, sir. Exactly. And it builds that vascular bed, that placental bed. It helps build the vascular bed for good blood flow. Okay. So the hormone progesterone relaxes muscles, and the hormone relaxin relaxes the musculoskeletal system muscles. So between the two of them, her whole pelvic girdle, you might say, ligaments connect joints, right? There's a ligament between the hips and the back, between the hips and the legs, there's ligaments. Around the uterus, there's ligaments. And all of those ligaments are relaxed because of progesterone and relaxin. And when you have ligaments that are relaxed, the joints aren't as stable, okay, because they're not tight and holding it in place. So muscles get pulled in different directions. So having low back pain is not uncommon during pregnancy. Okay. And then the immune system. Immune system isn't as active during pregnancy. It's very quiet. Okay. So she isn't at risk for infections. So the immune system, so if you have someone that has lupus and she's pregnant, lupus is an autoimmune disease, meaning that the immune system is overactive. So if she gets pregnant, then she's pretty comfortable during her pregnancy, more so than when she's not pregnant.
I have a question.
Yes.
It mentioned that during pregnancy, you have an increased amount of white blood cells.
Yes.
So, but they're still susceptible because they're immunosuppressed.
Yeah. Mm-hmm. Mm-hmm. Mm-hmm.
I just don't know how.
It doesn't make sense, but
No.
that's what you might see in lab work. Yeah. Yeah.
Okay.
So we've talked about how important folic acid is, and that for the growth and the development and the closure of the spinal cord. Okay, so pica is another term. It's an indication that your client has iron deficiency anemia, eating things that aren't meant to be eaten, chalk, dirt, things like that. Know what some iron-rich foods are. Meats in particular, organ meats. Okay, promoting dental hygiene during pregnancy is important. Any kind of infection in the gums or in the base, in the roots of the teeth can actually cause labor. The GI system slows down during pregnancy. So food stays in the stomach longer. So we're going to teach our client to eat smaller meals throughout the day. Constipation, common. Increased fiber. So as long as we know, even if you don't understand blood type incompatibility or RH incompatibility, as long as our mother is RH positive, we have nothing to worry about. Seriously. I mean, serious things to worry about. Okay. If we have RH negative status, then we're concerned about the mother's antibodies attacking a fetus. Okay. So anytime something, an antigen, anything that enters into your blood that is considered a foreign substance to your immune system recognizes it and will attack it, try to destroy it. Anything that's foreign, okay? So if you have type O negative blood, the only blood that you can receive is O negative. So if somebody gave you O positive blood, you're going to have a reaction to that. And you're going to get sick, very sick, develop a fever and chills. Okay, because your blood says, you're an enemy, you're invading our territory. Okay, so mom has there's an antigen on certain blood types called Rh factor. Okay, if she has it on her red blood cells and the fetus, or if she doesn't have it on her red blood cells and the fetus does during delivery, or if there's trauma during the pregnancy and there's an increased risk of the blood mixing with mothers, then the mother's immune system will develop antibodies and attack that Rh antigen that came from the baby's blood. And it's not a problem for that pregnancy, it's the next pregnancy. Okay, the next pregnancy, the antibodies could actually work on destroying the red blood cells of the fetus. Okay, it's called hydrops fetalis, and it causes severe anemia in the fetus. It's going a little deep, I know. Leopold maneuvers. Where is the baby? Is the butt up? Is the spine on the right or the left? Where's the head? Is it flexed? So we do these maneuvers. We can do this at the end of pregnancy when we're planning delivery. If we suspect, I don't know if, I mean, when I palpated my clients' abdomens, but not to the detail of a Leopold maneuver. I didn't do all the steps, but to get an idea if the baby's head was down. You can usually tell late, but we use ultrasounds, okay? Okay. So you don't have to know these particular steps.
I was
Just
just
know,
about to ask that.
yeah, you don't have to know the fundal grip or umbilical grip. You don't have to know the particular steps. Just know that Leopold maneuvers tell us the lie of the baby and the position, okay? And we usually do it before they go into labor. Okay, probable signs of pregnancy are what?
B,
Probable. Now remember, anybody remember?
Probable is what's determined by an ultrasound.
Objective.
Nope.
no, it's by a clinician,
It's the
by a
nurse
clinician.
touching
Yep.
and moving and
Yeah, so it's the client presumptive, clinician probable, because we're seeing things. Positively, ultrasound, heartbeat. Okay, that makes sense? Okay, we only have a few more minutes. I do want to do a little bit more here, and then we'll talk about, let's see, here she is. Now, I shared this with you, but you don't have access to it because it's on my OneDrive and I can't figure out how to fix it. So if you want to look at this again, you'll have to watch the recording. Okay, scenario, we have a client. She's an adolescent and she's pregnant. Not anything that she planned, okay? Her name is Abby. So she's coming into the office. She did a pregnancy test at home and it showed 2 lines. So she thinks she's pregnant. She is a little nauseated. What else could she be experiencing? What other presumptive symptoms? Could she be
Tender
breasts? Tender breast,
A missed
amenorrhea.
period.
amenorrhea,
Quickening.
Nausea,
quickening, yeah,
vomiting.
she's far, yeah,
Fatigue.
fatigue. Okay, good. And now we're getting ready to examine her, okay? So Amber is going to examine her since she's the nurse in the office. So she already talked to her, so we're gonna do a head to toe physical. And now we're coming to the speculum exam. And she looks in the speculum and she visualizes a cervix. So she looks at that cervix and she says, oh, yeah, you probably are pregnant. What does she see about the cervix? And what do we
Chadwick.
call it?
Chadwick.
Chadwick. What is the Chadwick?
It's
Softening
probably
of the
bluish.
cervix.
It's probably bluish.
Blue Chadwick.
Bluish.
Blue Chadwick. And Goodell,
Good out is soft.
good
Softening
and
of the cervix.
soft. Yeah,
Soft.
and Hagar sign is the softening of the
Soft.
isthmus
Right.
and McDonald's. Okay. Ballottement, we talked about, maybe increased pigmentation.
Right.
Yeah, those are probably, but the only time we can say, Abby, you're pregnant is if what?
You take an
Ultrasound.
ultrasound or a Doppler.
All right, good, good, excellent. So we're talking to Abby. We did her exam already, but we're talking to her while we're doing her exam. Is this the first time you've been pregnant? What is her obstetric history? Okay. When was the first day of your last menstrual period? You said January 4th. So we're going to calculate when her baby's due. So let's do January 4th. Back 3 months would be what?
October 11,
Huh?
October 11 to 23.
24.
Wow, that was fast. October, that's correct. So December, November, October. Yeah, October 11th, 2024, actually.
Of 24.
Mhm.
14.
And so that's her estimated due date. So that's the Nagel's rule. Okay. If we don't know when her last period was, the next best thing would be to do what? Ultrasound. So what's her GTPAL? How many times has she been pregnant?
0.
Yeah, one.
One.
Yeah, just one. So it's a G1, and then
Yeah,
all the
no.
other letters are zeros.
0.
She doesn't- yeah, the rest of them are zeros.
I'm sorry, I have a question about that. Wouldn't it be 2023, October
Yeah.
11, 2023 that she was due? Because then she would be pregnant
Yes,
for
yes, yes,
well
yes,
over a
yes,
year.
you're right.
Okay, I
You're
was like, I
right.
thought he
Yes.
was right when he said
Yeah.
that. Okay,
You're right, because when we go back 3 months, we're actually in the year 22. You're right. You're right. That can be
I was like, that was a
confusing.
long pregnancy.
She'd be
That was a
mad.
Feel
good,
like they're that long.
that was a good NCLEX question.
Yep. So the terms nulligravida, multigravida, prima gravida, multipara, kind of look over those. So remember, a pregnancy that ends before 20 weeks is a gravida. It's not a parity, and it's referred to as an abortion. Okay, whether it's spontaneous or medical abortion. Okay, so a pregnancy that ends before 20 weeks is called an abortion. A pregnancy that is delivered 20 weeks or later is a parity. Okay. A pregnancy that is delivered between 20 weeks and 36 weeks and 6 days, that's the preterm period. Okay. If it's delivered before 20 weeks, it's not preterm, it's an abortion. Okay. So then at 37 weeks, this baby becomes full term. And if it's 42 weeks, it's beyond. So it's a post-term baby. So when we talk to Abby, our client, she has a family history of cystic fibrosis and depression, okay? She has a brother with cystic fibrosis, okay? And we know that because her first day of her last menstrual period was January 4th, that she's 10 weeks and 5 days pregnant. There's apps that you can get, they do to determine that. So October 11th of 23 is her due date. Okay. And so she's going to come back next week. Should we hear fetal heart tones when we use our Doppler on her at this visit at 10 weeks?
Yes.
Yeah,
No.
yeah. We can hear fetal heart tones at 10. We can hear them as early as 9 weeks. Okay. Yeah, believe it or not.
I was able to
Okay.
hear mine at like 4.5 weeks when I was pregnant with both my last kids.
No, you were probably hearing your own heartbeat.
Unless my heartbeat was
Or-
like 167 beats per minute, it was not mine.
That is, well, that's not physiologically possible. Okay. Because we don't even see the heartbeat on an ultrasound at 4 weeks. Okay. Anyway, so what do you think, because of Abby's history, what do you think, what tests do we need to do for her?
A recessive gene test.
Okay, so we need to do some carrier screening, don't we? If we don't know if Abby is carrying the recessive gene for cystic fibrosis, then we need to test her. Because if she is, then we need to test the father of the baby. okay, to determine the risk for their baby, her baby, having cystic fibrosis, okay? So when we do an extensive medical history, it guides us to what blood tests we need to do, extra blood test, okay? Something not routinely done. So when we look at her history, we're looking for things like depression. So we need to screen Abby for depression. We need to ask her about travel. So we need to ask her all these questions. Her BMI is 19. Is she okay? Is she at a good weight? If her BMI is 19, is that a good weight?
I think that's under.
It's
That's
under.
good. That's good.
No, it's
That's
the,
good.
That she's healthy. Under
Okay,
18
what's
is malnutrition, right?
under 18.5 would be underweight. Okay, we would definitely be concerned if she was less than 18.2.5. Yeah. Okay, so at 18.5 to 24.99 is a normal ideal BMI. Okay, so we also see here that her father is an alcoholic. Okay, so that's something we need to keep an eye on. And an older sister with substance use. So we have to take all these things into account to plan the care for Abby and provide the support and education that she needs. Okay, so we've got just a couple more slides here. This goes through the gravidity and parity. I'd like to be able to do this with you, but you can do this on your own time. And then here, this goes through the test, again, the carrier screening versus the AFP test. The AFP is something we routinely do. And starting as early as week 11, we can do an AFP test. Now, this is drawing her blood again, but we're looking for markers of the pregnancy. So if a woman is pregnant, she should have some alpha fetal protein in her blood. This is what the baby puts off, okay? It's a protein that the fetus has, and it's found in the mother's blood. So we can draw her blood, and we can determine, is it a lot of AFP in her blood, or is it a low amount? If it's high, it's indicative of a neural tube defect in her baby. Okay? If it's a low AFP, it's indicative of Down syndrome. Okay. So you can kind of study these slides and it'll help you. If you want to meet with me and I'll go over it with you, I'd be glad to. Okay. So the next thing we would do here is to go over the results of all her stuff. So I'll do this during my exam review. Okay. I'm sorry I didn't have time to do that. All right. So next week. So this week, make sure you get your case study done and do the best you can possibly do. Okay. Learn from it. You've got, what else do you have? We did the quiz. Okay. So, and your discussion submissions. Do the case study first. If you haven't done either one, do the case study first and then do your discussion if you have time. Because a case study is a lot more weight. And then, so next week we start preparing for the exam that is in week 4. Okay, so I put a schedule out in the announcements. Has everybody seen it? In the announcements, you need to be checking every announcement. You need to be checking those announcements every day. Okay, to look and see what I've posted. So it tells you what days of the week and what time of day, which instructor is having a session, and you are invited to go to any of them. Okay, they will all be recorded and be posted in the announcements, so you can watch recordings. My recording is going to be Sunday night. Not this Sunday night, but the following Sunday night. At I think 7 o'clock is when I scheduled it. I don't remember for sure. You have to look. So what we'll do, we're not going to sit and just talk and go over a PowerPoint. Where you're going to ask me questions. And I could bring up a topic and we could talk about it and we can review it. There's also some short videos in there that you can watch. Brief videos about certain parts of certain concepts we've talked about the first 3 weeks through next week. Okay, so next week is labor and delivery. So we're talking about labor already. Okay, so we've gone through all of antepartum. Okay, so make sure you're looking at the documents I'm giving you and going to the book and getting into the book to answer your questions if you don't know. I'm available to meet with you to go over anything you feel like you need to go over. Okay, so you need to contact me. And then try to attend 2 sessions. Students that attend the review study sessions do better on exams. They really do. So you need to attend one. Okay. Any other study suggestions I'm willing to spend time helping you with? So week 4, your exam will be occurring the beginning of class, like we do the quizzes, and that's when you'll have to have your 2 devices. So next week during class, we'll go over what to expect during your exam. And I'll show you how to do the NCLEX question. I might do a quick video of that for you so you'll have it early. Okay? Show you how to do those NCLEX questions, because NCLEX questions is another thing that is very valuable in preparing for the exam. Okay?
Is there
I
a,
rushed through.
sorry, is there specific content for the NCLEX questions that we have to do?
Yeah, the antepartum and intrapartum.
Okay, and that's
So
due
you're
for
going to
next-
choose the category maternity, of course.
right.
And then under maternity, there's some subcategories and you want to choose antepartum, intrapartum.
Okay,
And you
Okay.
need to choose 50.
okay. Thank you.
Okay?
Is it the
And read through the
antepartum,
rationales.
postpartum or antepartum, intrapartum?
Antepartum, oh, you're right. We do need to do postpartum too. I forgot. So all 3. Yeah, because we'll be covering postpartum. I forgot about the postpartum because we hadn't been there yet.
So
Okay.
anti, intra, and post.
So make sure when you're doing those questions, you take your time also and read the rationales. That's when learning takes place.
Yeah.
Okay, reading the rationales. Why did you miss it? Why did you get that one wrong? And of course, you need to do 50 at a time.
Okay, thank you.
And you can, if you do 50 and you only get a 78 and you want a higher score, then do 50 more. It's worth it. Okay.
Great, thank you.
All right. Yeah, that's a lot to go through.